Understand the intent of what I'm presenting is not so much about the program I'm going to tell you about, but how it works successfully with all of our programs to reduce our run volume in the city of Pasco. So we talk about using all these and creating programs, but we found out usually there's more than one issue causing the problems that we see. And when we combine all of our 5Es with those of our community partners and their version of what they call CRR, we come closer to fixing all the problems for our citizens. There's more than one problem, and it takes more than one email. It's all about the data. As with any good model programs, we must start with the data. But first, let me tell you a little bit about our department. At the time we started our CRA, we had 4 fire stations. We had about 85 career firefighters, covering a city of about 70,000 citizens. We're an all-hazards department, including EMS, with response EMS as well as transport for EMS. And our story starts with the crews, who were always complaining, all we ever do is pick people up off the floor. In 2017, we created our CRR position because we know our community was growing faster than we could, and we had to do something about it. We had to find a better way, a more efficient way, to keep our community safe. Before I get into our data, I'll tell you that this is like most departments who start this process, our data was garbage. So in order to get things happening, our data chief and our deputy chief worked with a data analyst from our city, trying to clean up some of the data, trying to make sense of it. By the time they got it done, a couple months later, they came up with a couple of reports, but every report had an asterisk to it because they couldn't verify the data numbers, but what they could prove was some very good storylines. So in 2017, we ran 5,510 calls, of which 78% of those were EMS, 40% of those were mainly ground level falls or lift assist with older adults. Our call volume was increasing faster than our population, and we could show a high number of repeat patients, which is why the firefighters said all we ever do is pick people up off the floor. Data showed that that really wasn't true. We had some large number of kitchen cooking fires. Who would have guessed that? But what data did show was that we had a problem with repeat patients causing a high volume of calls. What we could prove is that 3% of our patients were responsible for 30% of our ambulance calls. Most of them for lift assist or other non-transport required issues. Great night, just listen to me talk. So the story shared here, which I'll just have to tell you about, is just representative of one of our stories last year. So the Smiths, so this of course maybe is not real, but representative of what we do here and where we got started with this. So the number of calls to this address, or what I could find later, we couldn't really verify every call to this address. And again, that was because our data issues. Some of the problem was when we do EMS reports or when we go to a call, if it's not a medical transport, we didn't always do an EMS call. So sometimes it was just done as an inverse. And sometimes that inverse wasn't done with the correct address or any personal information in it. So it's hard to go back later and actually correlate all the calls to a specific address. And that is one of the things we fixed. So we transported this family many times for the husband and wife both, but many times we did not transport them. But if you notice the issues noted in the reports, falls, cluttered home, confusion, poor living situations, dementia, a leg amputation, and failure to thrive. What I want you to notice is we started with a couple of calls a year, to a bunch of calls a year, and then back to just a few calls a year. When they started getting really sick, we had a bunch of calls, but obviously they were not getting the help they needed. By the end of the 5-year span, they were both too tired and exhausted to call for, they're both too tired and exhausted to call for help, especially help that wasn't getting them what they needed. We, the fire department, did what we could. We did what we were trained to do. We reported them out to our area agency and other department or other community members, and we always figured these community members would take care of the people that we reported. But unfortunately, nothing helped. The couple ended up in nursing homes, separate nursing homes. The house ended up abandoned, and for some time the city and the family had to deal with issues of the house because it sat abandoned for so long. So before I get into the next part, I want everybody to understand. It may sound like I'm casting some blame on our EMS, or the hospital system, or the social agencies that are supposed to take care of people. I'm not. However, that was the attitude I had when I started this project, and I don't suggest you take that attitude to your community, but that's a different presentation. I did start talking with the agencies in our area to try and find out why this story happened. What was going on in our community? Why were our repeat patients not getting the help we referred them to? I ended up with community partner meetings, trying to find out why these agencies, how they work, where they go to, what they do with the information we give it, how the referrals come in, and the process they go through. What I found out is what you already know: the system is broken. Simply put, the system is not designed to take care of people who cannot take care of themselves. However, we did find a group that had already been looking into this problem, and through a grant, they were able to reduce hospital admissions and follow up ER visits with patients that were sent home after long hospital stays. Our medical officer and I sat down with this group and asked them what they did, how they were able to reduce the hospital readmits. This is what they found. There are common issues among all patients. The social determinants of health was one of the biggest aha moments. There's always more to the story if you just sit down and listen. What may be a simple issue for an average healthy adult becomes a mountain when you're faced with other small problems. Patients were not connecting with resources that were available, which we already figured out now. Social service agencies cannot respond to a client's home without the consent of the patient. In other words, you have to get the patient to say, please come to my house. Well, let's go through that scenario for a second. You're 80 years old, you fell at home, tripping over the clutter in your house, you break your hip, you go to the hospital, you get fixed up, you go to rehab for a couple of weeks, they send you home with a pile of papers that's all written in shorthand medical, and somewhere in there there's a prescription for some pain pills, physical therapy, a bunch of numbers to call if you need some help, which you don't because A, you don't feel good, B, your house is still cluttered, you don't want anybody to see it. The next thing you know, your phone rings and a very nice sounding person on the other end says, hello sir, I'm from the Area Agency on Aging, I'm here to help, all I need is your social security number and for me to come to your house and maybe we can find you help, which always ended up to the phone call, right? The biggest difference the diversion grant group got was they had the ability through the hospitals to just automatically show up at patients' homes. So they weren't waiting for the phone call, they were just automatically showing up, introducing themselves, and talking about why they were there, what was going on. And it made a huge difference. The important discovery was the problem they were facing was there was so much red tape with all these social service agencies on how to get patients admitted into their systems. And so when you had a patient advocate there, it made a huge difference in being able to get those patients that help they needed. Another part of a good CRR plan is drafting the trial of your plan. We didn't really do that. We thought we had something good, and we went with it. The medical officer and I went to our local agency on aging, and we were already doing referrals to them, so we started with them. And we also started with Meals on Wheels. We were already partnered with them anyway through a program through the NFPA now called Steps to Safety, and we were trying to get that program up and running, so we were already working with Meals on Wheels. They were going out to people's homes already, and they were calling us and saying, hey, we went out to Jones's house, and we could hear a beeping smoke alarm when we got to the front door, so they were already calling us and saying, hey, you should go visit these people. What we also figured out is when we were going out and visiting people to deal with home safety visits and smoke alarms, they were probably people that needed help with cooking, needed help with food. And so we were already kind of working with each other on that anyway. So it made it easy to start small with those partners. After the data piece was done, we moved into getting our 5 E's together. So we, of course, created this great model program using all the 5 B's. We figured out how we were going to do this. We're going to reduce falls by getting grab bars, getting them installed, all that good work, right? So we had this great program going. The big thing we had to do, of course, was go to our crews, and we had to work on our data because we needed to be able to track patients. So we trained and retrained our crews on how to properly enter calls that were put into the EMS system. Had to get them to say, hey, yes, at 2 o'clock in the morning, it's easy just to fill out that red spot, but really we need good data if you want us to help you not have these repeat patients. What we also trained them to do was look for other social determinants of health when they were in the home, and then report that patient. So that story I just talked about a little bit ago, the very first call, the paramedic came back to the station and said, they're going to be repeat patients. And I said, great, we now know that we have enough experience. We can identify them on the first call. Don't wait for that second and third call. Call us, get us, don't wait for us to find that medical report 3 or 4 times. Call us and say, hey, I went to this address, I think we need help. So with these plans in place, the medical officer and I started as new people. At first, we had kind of walked this fine line because people were wondering why we were there. But by adding programs and information release form on our medical calls and having the operations crews explain the program and somebody would be contacting them, we got through that piece pretty well. And it helped us clear a lot of the red tape that we were having with some of our other partners. It also helped out a smoke alarm program. So sometimes when we would call people and say, hey, we want to come out and help you, they would still be very hesitant, right? People were hesitant about coming out to your house, what's going on. But I could call up and go, hey, one of our medics heard beeping smoke alarm at your house when they were there the other day, whether it was true or not. Sometimes we just use the excuse. And I have this program, I'll come out to your house and help you fix that beeping smoke alarm. And of course, people want us to come out and help the beeping smoke alarm, so why not? And then it was easy for us to get in there and start talking to them while we were there. Our program had an immediate effect. We were the fire department, in uniform, people love us, they're happy to help us help them solve their problems. But we listened a lot to people too. So what was happening in their lives? What else did we know? We weren't there just for a fall, we were there for other issues. And so we wanted to find out all the help that they needed so we could get all the partnerships going for them. By being that go-between contact, we could help people get all the help. We could get all the right information to the partnerships so they were ready to go when they got there. What we didn't count on was the 10 to 20 hours it took per patient to get through all the red tape for all these social service agencies to get them the information and get things going. So we knew that wasn't sustainable. So we created a business agreement so we could share information. So we went back to our area on agency and we formed an actual business partnership with them so we could exchange information back and forth. And this is a sample of one of the reports that this gets emailed to them every day with all the calls for slips and falls, strips, ground level falls for the last 24 hours. And so this report goes out. When we first started doing this report every day, it had 5 to 6 names on it every day, and most of those names were repeat patients 3 or 4 times a week, months on end. So this is the report that we get back with part of our business agreement from the agency. So they were getting back to us with these names and telling us where they were, was an existing client, what service they were being offered. If they weren't a client, where were they in the process of trying to get them connected? And what it allowed us to do then is go back and say, wait, we know the Smiths already had services being offered. Why aren't they getting those services? Are we not enough? And then we can go back and say, hey, your services aren't working, and try to fix that. If you notice the bottom one, this is one of the big things we realized was an issue. So most of these agencies, if they can't reach them on the phone by the 3rd phone call, they send them a packet. And the best way I can describe it is like a Sears and Roebuck catalog that goes to their house, right? So again, you're 80 years old, you fell and you broke your hip because you had clutter in your house, and now somebody's sending you a packet saying, here, we can help. And it's got everything from wheelchairs to ramps to food programs to you name it, right? So that just instantly goes to the trash. So we were able to identify, if I saw this, that Peter was not being able to get contacted, they were sending him mail, that was like, do I need to get back to Peter's house right now and find out why he wasn't answering the phone? So we had great results. We made great contacts. We got information handled. We were reducing our 911 calls. But again, we still had some problems getting to some of our patients. But again, it took more time than the medical officer and I had. So we had other duties and jobs that we needed to do. And spending the 10 to 12 hours per patient was just more than we could do. So we started looking around at a lot of developed programs. Some we hear about this week. Some amazing programs here. And decided we just really didn't have the capacity to do that at the time in our department. But we started looking around at some other ways to do it. And again, back to this group that had been doing the hospital readmission program. So we went to them and actually contracted with them for their community health workers. And we created a program called the Paxco Resource Navigator. And many of you in the medical field will recognize the term as needed. It's actually a Latin phrase that translates to as the situation arises. And I actually found that much more fitting what was actually happening in our community. We staffed the program with a community health worker. They weren't medically trained, they were really just there to do those home assessments, make contacts with social service agencies, and get that person connected. They also didn't cost as much as the paramedic runners. That was nice to my budget. We contracted with this agency, and so they started moving. So again, working small, we were only working with our area agency on aging and Meals on Wheels. And we started contacting the 60 plus patients that we knew had called 911 for more than 100 times that year. We started in the last quarter of 2019. It was just a half-time position. The chief managed to find some budget desk for us because we knew we had to get this program started. And of course, we all know what happened in 2020. But it didn't take us long to prove the program needed to be full-time. And it did not take us long to prove the program worked. In 2020, it was even more important to have people contacting us, those in need. We had immediate results with most patients. The services do take time to set up through traditional agencies, and some patients needed extra help, as we were well aware of. So our resource navigator actually went out to the community and started finding more partners. This is just some of the different partners we have, and some of our partners we actually have business agreements with, and some of our partners are just community resources that we work with. What we learned and why it works. Many of these agencies have their own CRR program we figured out. So each of them have their own model programs that they use, and they have their own version of their alphabet E's. And we started realizing, hey, our E's can help their E's, right? So we started working back and forth and making those connections. And our resource navigators started working with their resource navigators on a regular basis. So they have meetings every couple of months. Sometimes it's virtual, sometimes it's just phone calls. But they're talking to each other about each other's patients now. So we actually are developing, because of our program, our local hospitals now have their own community health workers, and they contact each other. The cities have all gone out and created their own community health worker programs. So now, instead of waiting for those 911 calls to even come in, our community health workers are now working with that network of other health workers in the community, and they're finding people before that first 911 call ever happens. They're even working with our local school district, finding those families that they know are slipping through the cracks and getting services to them ahead of time. So when we started our program, there was only a few of us, but we know the program has worked. We've reduced individual patient 911 calls by 77%. Instead of 3% of our patients being 30% of our US calls, it now takes 30% of our patients being 50%, so we know we still got work to do. We do have the challenges. The biggest one we realized is mental health challenges. So this year, we actually, starting in 2023, we actually went out and hired a full-time social mental health worker to add to our resource navigator, helping. He actually can respond right to the emergency scene as well, de-escalate the call that's going on, allows the crew to get back to more emergency work, and then he uses his resources to find community help that patient get to the community help. So for me, this is the best part. This is what our report now looks like. The daily goes out in the daily email. This looks like this 3 or 4 times a week, and it makes me happy every time I see this. It now frustrates me when I see names on the list. So, but again, that's that's where we've gotten to and appreciate the work that our community health workers do. So, again, in closing, I just want to say, it takes more than money, it takes more than one service. We always talk about our partnerships and building model programs, but realize that they have model programs too. And when we actually sit down and take the time to make sure our model program